Good afternoon, good evening, or good morning, depending on from when and where you're joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for November 2018. The National Diabetes Prevention Program, Changing Lifestyles to Prevent Type 2 Diabetes. We have an exciting session. But first, a few housekeeping slides. Public Health Grand Rounds has continuing education available for physicians, nurses, pharmacists, veterinarians, and others. Please check out our website for more information. The course code is PHG10, and this is our disclosure slide. Grand Rounds is available on all your favorite web and social media sites. Please send the questions to grandrounds@cdc.gov, and we will try to include your question in the Q&A today. Want to know more about prediabetes and preventing it? We have a featured video segment on YouTube and our website called Beyond the Data, which is posted after the session. This month's segment features my interview with Dr. Ann Albright. We have also partnered with the CDC Public Health Library to feature scientific articles about the topic. The full listing is available at cdc.gov/scienceclips. Here is a preview of our upcoming Grand Rounds topics. Please join us if you can. And in addition to our outstanding speakers, which I will give a special thank you to Dr. Pryor, who is joining us from California. He had to evacuate his home due to wildfires. I'd also like to acknowledge the important contributions of the individuals listed here. Thank you. And now for a few words from CDC's Deputy Director, Dr. Schuckett.
Today, 30 million Americans have diabetes, and another 84 million Americans, or 1 in 3 adults, have prediabetes. You may never have heard of this, but today you'll find out why prediabetes matters and what you can do about it if you or a loved one has it. Prediabetes is characterized by blood glucose levels that are higher than normal, but not high enough to be diagnosed as diabetes. People with prediabetes have an increased risk of developing type 2 diabetes, heart disease, and stroke. Prediabetes does not mean an inevitable progression to diabetes. Research shows that people with prediabetes who take part in a structured lifestyle change program can cut their risk of developing type 2 diabetes by more than half. People over 60 can cut their risk by nearly 3/4. The National Diabetes Prevention Program, or DPP, is designed to help people make changes in diet, exercise, and behavior. The program starts with weekly lessons the first 16 weeks, then monthly for another 6 months. These can lead to lasting health improvement. The goals are to lose 5 to 7% of body weight through healthier eating and to get 150 minutes of physical activity a week. It doesn't take a radical weight loss to make a big impact. The impact of this program can last for years. Research has found that even 10 years later, people who completed a diabetes prevention lifestyle change program were 1/3 less likely to develop type 2 diabetes. Most people who have prediabetes are not aware of it. Increasing screening is key. The CDC-led National Diabetes Prevention Program is a partnership working collectively to prevent or delay onset of type 2 diabetes in adults through the delivery of an evidence-based lifestyle change program. Today we will hear about how partners are delivering this program across the U.S. and how private and public health care insurance providers are supporting this effort. The national levels of type 2 diabetes have been increasing along with the obesity epidemic and make scaling up the DPP an urgent national priority. Working together, we can make it easier for people with prediabetes to participate in evidence-based, affordable, high-quality lifestyle change programs to reduce their risk of type 2 diabetes and improve their overall health.
And now for our first speaker, Dr. Ann Albright.
Thanks, Phoebe. It's really a pleasure to be with all of you today. As you heard, there are over 30 million people who have diabetes. That's about 9.4% of the US population. It's expensive, $237 billion in direct costs and $90 billion in reduced productivity and disability. Prediabetes is a condition where blood sugar is higher than normal, but not high enough yet to constitute type 2 diabetes. But as was noted, it does put you at increased risk for other serious health problems, including heart attack and stroke. Prediabetes really is a significant health issue in our nation. So as we work to improve the outcomes for those who already have diabetes, it is imperative that we really do focus and invest in preventing new cases of type 2 diabetes. Fortunately, we have strong evidence that for the prevention or delay of type 2 diabetes in those at high risk. We have multiple randomized controlled trials that have been done in the US and around the world. The most preeminent one done in the US is referred to as known as the Diabetes Prevention Program Research Study, which was led by NIH with critical support from CDC and others. The trial was done in adults, and about half of the study participants were from high-risk ethnic groups. The interventions tested were lifestyle program, the structured lifestyle program, the medication metformin, which is used to treat type 2 diabetes, and a placebo. The intensive lifestyle intervention did consist of this structured curriculum that addressed diet, physical activity, and behavior change modification. The intervention did involve 16 weekly sessions and then 6 monthly sessions over the course of a year. The goal was 7% weight loss in 150 minutes of physical activity. So let's take a look at the results from the study briefly. The Lifestyle Change Program did reduce the incidence of type 2 diabetes, as you heard earlier, by 58%, 31% for those using medication. The 58% reduction was seen in those with a 5 to 7% weight loss. And as was noted, those over 60, 71% reduction in the development of type 2 diabetes. Exciting is that this is a long-lasting impact. Not only have we now been studying the trial for 10 years, we now have 15-year data that shows that after 15 years, there still is a 27% reduction in the development of type 2 diabetes. So this shows both prevention and delay. Very importantly, though, we also have research trials that have been done in the real world. And so that is critical to allow us now to transition from these research studies into the actual implementation of the lifestyle intervention. We also, by the way, have support from very esteemed bodies like the U.S. Preventive Services Task Force and the Community Guide, who all recommend this intervention. So to implement this proven lifestyle intervention nationwide, CDC did establish the National Diabetes Prevention Program, officially called the National DPP. Congress authorized CDC to establish it, and so that's good news for all of us. The National DPP is the largest national effort to mobilize and bring together effective lifestyle change program to communities across the country. It serves to unite all sectors so we can really achieve national scale. The National DPP has 4 overarching strategic goals: increase the supply of quality programs across the U.S., increase demand for the National DPP among people at risk, increase referrals from healthcare providers, and increase coverage among public and private payers. All of these critical elements have to work simultaneously since all are required. Let's take a look at where we are in the progress to achieve where we are in achieving the goals in each of these areas. So first, let's take a look at increasing the supply of quality programs. As you can see, the trajectory is showing a significant increase in the number of organizations who are delivering the lifestyle change since its launch. There are currently close to 1,800 organizations offering the program in all 50 states, in DC, and in some of our U.S. territories. Many of these groups have multiple delivery sites. The program is being delivered in person, online, and through distance learning by a whole array of various kinds of organizations. CDC's Diabetes Prevention Recognition Program plays a key role in assuring the quality across these many unique organizations. It's part of the national DPP. We award a recognition in 3 categories: pending, preliminary, and full. These standards are updated every 3 years. They are really a critical part of the recognition program. They are the heart of the recognition program, and they are updated every 3 years, both to stay in alignment with the science of type 2 diabetes prevention, but also to respond to the lessons we have learned through the program delivery and the analysis of participant data. There are many benefits of CDC recognition. We have now data that allows us as a country to look at how we are doing in program outcomes across the nation. It also is very important now for those who are providing coverage for the intervention. Many of these payers now require CDC recognition. It also allows support to be given to those organizations who are delivering the intervention. We can provide assistance, training, and resources, and also can be a very effective part of marketing your program. So let's now take a look at increasing the demand for the program among people at risk. The number of participants enrolled in the National DPP Lifestyle Change Program has really grown rapidly. This graph represents trends in cumulative enrollment of almost 250,000 people for whom we currently have data. There are many more people enrolled in the program, but data is not yet submitted for them. We do have a system in place to track these numbers in real time. Since 2016, CDC has worked with the Ad Council, the American Medical Association, and the American Diabetes Association to launch the first national prediabetes awareness campaign and get people to complete a brief prediabetes risk test. We've used humor to engage people in the campaign. We've used a comedic doctor talking to patients, cute animal videos, which we know people watch. And we also, which is showing us now from what we've achieved so far in the campaign, about 3 million people know their risk for prediabetes as a result of this campaign. We're really excited to be launching the 3rd phase of this very successful campaign on November 14th, tomorrow, World Diabetes Day. The new campaign assets will focus on the message of 1 in 3 adults has prediabetes, and will again use humor to reach people at risk and encourage them to take action to know where they stand. Please take the test yourself. Share it with everyone you know and share it in your social media channels. So now let's turn to increased referrals from healthcare providers. CDC works with many different national partner organizations to help identify and refer at-risk individuals to CDC-recognized programs who offer the intervention. Each of these groups is working with the clinical care community or implementing systems, some involving the electronic health record, to increase healthcare provider screening, testing, and referring people with prediabetes to CDC-recognized organizations around the country. The role of healthcare professionals really is critical. And now the last strategic goal is increasing coverage among public and private payers. Our goal since the inception of the National Diabetes Prevention Program has been all payer coverage, and we have made significant progress. Many public and private insurers are offering the National DPP Lifestyle Change Program as a covered benefit in specific markets or geographic areas. There are some examples of these commercial health plans listed on the left of your slide, but these are just some of them. In addition, another 3.4 million public employees and their dependents in 19 states have coverage, and other states are working towards this goal. We also support work to make the National DPP Lifestyle Change Program available as a covered benefit for Medicaid. There is a lot of energy in this area right now. Currently, there are 9 states who have full or partial coverage through Medicaid authorities, demonstrations, or pilots. Beginning in April 2018, the National DPP Lifestyle Change Program became a covered service for eligible Medicare beneficiaries. It's called the Medicare Diabetes Prevention Program, or MDPP, and is part of the National DPP. You will hear more about the MDPP from our next presenter. Together, all of this work has informed the development of an online toolkit to assist public and private payers and employers pursuing coverage for the program. We encourage you to look at that toolkit. In response to the program's tremendous growth, we have recently launched our newest resource, the National DPP Customer Service Center. The Customer Service Center really provides a hub of resources, training, and technical assistance for CDC-recognized delivery organizations and other national DPP stakeholders nationwide. You can access numerous resources, including toolkits, training videos, and very importantly, connect with others in the national DPP community. You can also engage with experts at CDC and other organizations for technical assistance. The national DPP is bringing all sectors together to unify efforts and get this highly effective intervention implemented nationwide. In addition to this very critical intervention, we also need interventions that focus on the whole population because we need fewer people ever developing prediabetes, and those with prediabetes will benefit from this as well. But they are both necessary, not one or the other. This really is our opportunity to make a significant impact on type 2 diabetes prevention, and the data tells us we must all succeed. Please join this effort and stay tuned for even more new exciting developments that are coming your way. You will now hear from Nina Brown Ashford, Deputy Director, CMS Innovation Center, Prevention and Population Health Group.
Good afternoon, and thank you, Anne, for that overview and introduction. I will note I also love cute animal videos, so very, very excited about that. So I'm going to provide a little bit of an overview. As Anne mentioned, we are now covering the diabetes prevention program as a covered service under Medicare, which we are very excited about. So I'll be talking a little bit about that coverage, as well as addressing some of the key components of the MDPP outlined here. So we know that MDPP works to prevent high rates of type 2 diabetes among older Americans. And so when we look at how type 2 diabetes is affecting Americans 65 years and older, we know that about 25% are living with type 2 diabetes, and about 50% of individuals, older Americans 65 or older, actually have prediabetes. We estimate that care for older Americans with diabetes costs Medicare about $104 billion annually, and this number is continuing to grow. Seeing that this was a big issue, the Medicare Diabetes Prevention Program model test, which was implemented by the YUSA through a Healthcare Innovation Award, actually served 7,800 Medicare beneficiaries. And what we saw was that it was wildly effective in terms of reducing weight and allowing beneficiaries to achieve weight loss, as well as reducing costs. And so we went through rulemaking to expand the Diabetes Prevention Program as a covered Medicare service and create a new supplier type so that these individuals who delivered DPP could actually enroll in Medicare to provide the service. So we know that DPP, as Anne highlighted, really does a great job of promoting healthier behaviors for eligible Medicare beneficiaries at risk for type 2 diabetes, as well as decrease overall Medicare costs. So I wanted to highlight some of the specific criteria as far as which Medicare beneficiaries are eligible to be able to receive MDPP services. So it is available for Medicare Part B and C beneficiaries as long as they meet one of the following eligibility criteria. So having a BMI or body mass index of at least 25 or 23 if self-identified as an Asian American, meet one of 3 blood test requirements, and they cannot have any of the following diagnoses or conditions listed below. So the MDPP covers up to 2 years of services for eligible beneficiaries. So in that first year, which is really that core set of services, we have months 0 through 6, and these are 16 sessions that are available to beneficiaries that are offered at least a week apart, and they are able to be attended regardless of weight loss. In months 7 through 12, we then move on to the core maintenance sessions, and so these are 6 monthly sessions, again, available to beneficiaries regardless of the weight loss that they achieve. In months 13 through 14, that's where we move on to the ongoing maintenance sessions. And these are 12 monthly maintenance sessions. And in order for beneficiaries to be able to attend these sessions, they must have achieved and maintain at least a 5% weight loss, as well as meet the attendance goals in order to remain eligible. An important thing to note is that this was expanded as an additional preventive service. So there is no copay for beneficiaries to receive this service. It does leverage the CDC's approved curriculum, and they can attend in-person sessions, and there are a limited number of virtual makeup sessions that are allowed. So what we really try to do with this service is to develop it with a performance-based payment. So they are really based on meaningful outcomes such as beneficiary attendance and weight loss. So as you can see here, within the first 6 months of the program, a supplier could actually receive a reimbursement of up to $165 if a beneficiary attends all sessions. And if they meet the weight loss targets, they could achieve $325 reimbursement. For the full 12-month program, if a beneficiary went through the entire program but didn't achieve any weight loss goals, they could receive $195 or $445 if they achieve all of the goals. Sorry about that. I talked faster than I advanced. One important criteria is that MDPP suppliers must actually adhere to the requirements to establish and maintain enrollment as a supplier. So CDC recognition is the crux to their enrollment, and this really has to happen first. So they have to have CDC preliminary or full recognition in order to be able and eligible to enroll in Medicare. They have to obtain a national provider identifier through the National Plan and Provider Enumeration System, and then there are a couple of enrollment options that they can utilize to enroll in Medicare. So they could do this using the online system that we call PACOS, or they could actually submit a paper form. I will just note there is about a 90-day faster turnaround for them to enroll using the online system versus the paper form, but there are those two mechanisms available. If you are already enrolled in Medicare, so you are already providing services as a Medicare provider, you must actually re-enroll as an MDPP supplier. Because this is a new supplier type, we had to work really hard to develop enrollment requirements that would allow us to be able to identify these types of suppliers. And then in order to maintain enrollment in Medicare, you actually have to maintain compliance with the CDC's recognition requirements. As I mentioned, that is the core of the enrollment. As well as the MDPP supplier standards, which are outlined in the physician fee schedule final rule in which we expanded the program. So one thing that I like to highlight, because there is a little bit of confusion, the MDPP is under the National Diabetes Prevention Program umbrella. And so we do like to highlight this. This really is a joint partnership between CMS and the CDC. And I always joke that once the rule was final, CDC and CMS were married in holy regulatory matrimony. And so we work very closely with our colleagues at CDC. They're a wonderful team, and it's been a really great experience. But CMS is really the payment, enrollment, and oversight arm of the MDPP program. And so the suppliers receive payment from CMS, and they have to remain compliant with those criteria that I outlined earlier. We really view CDC as the quality assurance arm. So the MDPP suppliers have to maintain that CDC recognition, follow the quality standards, which includes the use of that approved curriculum. We want to make sure that our beneficiaries are receiving a quality program and benefit. So what can you do to help? Screen, test, and refer your at-risk Medicare patients. So you can screen them using the CDC's pre-diabetes screening test. There is a link here. You can use one of the 3 blood tests that Ann highlighted and are also listed here. And please do refer your at-risk Medicare patients with pre-diabetes to one of their nearby MDPP suppliers. We do have a supplier map on our CMS website where you can go in, put your address, and see where the nearest MDPP supplier is to you so that you can enroll either yourself or refer your beneficiaries to enroll. How else can you help? So we really need to increase MDPP supplier capacity. This is a new service. We know that new services take time to roll out and ramp up. So suppliers were able to begin billing for the benefit beginning April 1st of this year. So we know that there's going to be a ramp up period for folks to get enrolled in Medicare. So encourage CDC recognized delivery organizations to enroll as MDPP suppliers. Encourage organizations to actually become CDC recognized so that they can eventually enroll once they've met that preliminary recognition, and then educate CDC recognized delivery organizations that MDPP is out here and that there are a ton of resources on our website available to help you enroll in Medicare to be able to bill for this service. Lastly, really work to promote awareness of prediabetes among the Medicare population. As I said, about 50% of Medicare beneficiaries are pre-diabetic, and many of them don't know it. So, have folks get screened and learn their status, as well as encourage providers to screen, test, and refer patients to MDPP suppliers. So if you want to know more, there are a number of resources here, both on our website at CMS as well as CDC's website. And now I will turn it over to Dr. David Pryor, who is calling in from California, and Phoebe will advance his slides. Thank you.
Well, thank you very much, Nina. I hope everybody is able to hear me. Very much pleased to be here with you today via the phone. As was mentioned earlier, I am right in Southern California in the midst of all of the fires, and good news is that after being evacuated from my home for the last 5 days, it looks like I'll be able to return today. So that is the good news. But again, I am a Regional Vice President Medical Director with Anthem Blue Cross. And as many of you know, Anthem is a national insurer with about 40 million medical members across the country, and I work in our California division. And wanted to talk a little bit about our implementation of the National DPP Lifestyle Change Program over the last year or two, and talk through some lessons learned through that, hopefully. Our journey with the National DPP program really began in August of 2014 when the U.S. Preventative Services Task Force issued a recommendation stating that intense behavioral counseling interventions could promote cardiovascular disease prevention. And so we took notice of that and looked around, and we're excited to find that the National DPP Lifestyle Change Program met all the requirements for this recommendation. So really that's how it started for us. And in August of 2016, we were able to offer this as a fully covered benefit for our medical members in California. And as we go to the next slide, this really has been a tremendous offering for our employees, our members. It's been a win-win situation. Many of our large health plans always ask us the same question. Well, we appreciate what you do. You provide insurance for our employees, but how can we continue to improve health, bring more and more quality to the healthcare experience, and at the same time, as a large employer, how can we save on healthcare costs? And so what we certainly know through our data is that members with diabetes do cost more than members without diabetes. Our data tells us that health plan costs for members with diabetes a little over $11,000 as opposed to $4,400 with those members that don't have diabetes. So certainly it's really an easy proposition that if we can keep people healthy, if we can prevent people from developing diabetes, we can improve their health, the quality of their health care, and we can save costs. So that was really, again, that win-win situation. So the next step is, well, how do we go about implementing the National DPP program? And so we decided early on that we were going to use vendors to help us implement the program. And we decided that the best way to reimburse for this was to run all of these visits through our claim system that we already had in place. So our claim structure allowed us to really align with the CDC quality and fidelity metrics. And as I'll talk about in the next few slides, we have 4 milestones which we pay our vendors, and it's worked out very well. So the next slide goes into more detail about these milestones. So milestone number 1, when somebody enrolls in the program, that's milestone number 1, and we make a reimbursement to our vendors at that stage. When they have meaningful engagement through 4 weeks, that's milestone number 2. When they continue that engagement up to 9 weeks, they've reached milestone number 3. And then hopefully, if everything goes well, when they're able to reach that greater than 5% weight loss, sometime between milestone 3 and end of 12 months, right, between 9 weeks and 12 months, that's milestone 4, and that is the last payment that our vendors receive. And so obviously, we didn't want to just kind of pay a fee, and if people aren't able to continue with the program, that money is kind of lost. So these milestone payments really helped us to manage this relationship with our vendors. The other question on the next slide is, how do you pick the right vendors? And what we found very quickly with our clients is we have very diverse needs. Some of the clients that we insure and provide insurance for are large municipalities. We have large school districts, but we also have tech companies. Let's say in the San Francisco Bay Area, for example, younger employees, very tech savvy, again, different ethnicities. So we had a lot of different needs, and we realized that it wasn't going to be just one size fit all, not just one provider that's going to provide DPP, but that we really needed to allow choices so that we could have the best fit. And the next slide here, again, talks and amplifies on that just a little bit more. So we knew that our vendors needed to have kind of a national network of organizations. We wanted kind of bricks and mortar community organizations, as well as the digital solutions as well. And you'll see some of the vendors here, even from Weight Watchers to LARC and Sclera. And so again, Solera was our company who has relationships with many of these vendors, and they're contracted. So they were our first major DPP vendor in California. And then we've also added on Omada, which is a pure digital solution that really appeals to a lot of our tech-savvy customers. And the next slide, again, talking about choice. What we've learned so far is that choice really does drive the engagement. So really finding the right DPP provider for the members is one of the major determinants of success. If they're using a service or a provider who is not really aligned with their interests and goals, it's not going to work. And so this choice has been very valuable for us as we've moved forward. The next slide now is really wanted to emphasize a little more of why choice matters and what's the preferred delivery. So our data so far has shown us the following, and may not be a big surprise to many of you, but our younger members, let's say 18 to 24, 25 to 34, that range, they often opt for the digital or virtual solutions. Okay? As we see our membership get older and they age, you'll see a little more mix, Weight Watchers becoming more popular as people get older, and other community organizations. And so overall, I guess as we kind of distill all of our data, we found that more people tend to opt and start with the digital virtual provider, if you will, but that we've actually had more success in some of those achieving those weight loss goals with the either Weight Watchers or community organizations. The kind of brick and mortar, you go in, you check in, you deal with somebody in person. For us so far, we've had a little bit better overall results in the weight loss, but I think that continues to evolve, and we kind of really push to make sure that our digital providers are engaging in the right way. But those are some things to certainly consider. I wanted now to go over just a few case examples of how we've implemented this. I work in our commercial division, and we have different segments. We have like individual accounts, we have small group accounts, and we have these very large group accounts with hundreds of thousands of employees. And so we had different strategies for each segment. So this slide here talks about our small group case study in California. Again, small group is typically those small businesses with 100 employees or less. So in this program, we actually started and directed the individuals in these small groups to take the CDC prediabetes risk test to determine their type 2 diabetes risk. We actually ran 4 campaigns between 2016 and 2018, and more than 60,000 received a series of emails referring them to take this risk test and find out what their status was. Here are some of the results. So as of August of this year, we had 1,811 members who actually committed to the program. They took the test, they committed to the program. Of those members, 65% remained actively engaged, and 24% of those members had achieved the 5 to 7% weight loss goal. What we found is that incentives were important. We actually gave Fitbits after the completion of the 4th week that helped to keep some of the momentum going. We also learned that those employers who were very engaged, so it was the vendor engaging the employees, but also the employer, right? At the same time, working, engaging, reminding the employees to take advantage of this benefit. That seemed to work the best. Also, our vendor, Solera, in this case, kind of used very sophisticated and slick emails to outreach and to get the employees excited. So they've had a lot of work with implementing these programs and learned that you can't just necessarily send a standard email out. You have to sometimes use some animation and some other little tricks to get people excited. And so next steps, we're going to be, at the end of this last quarter, sending out a 5th campaign focusing on our small group members. The next slide is a little case example from our large group business. These are often large employer groups with over 10,000 employees, and wanted to give you some highlights there. The same thing, we directed the members to the CDC prediabetes risk test. We had different mechanisms. This was actually a large school district that had some early retirees, over 38,000, that they received a newsletter article linking them, giving them information about this program and this covered benefit. We also had another track for those district employees who were active employees, over 60,000, where they received a series of emails sent out by the district in this case, encouraging them, telling them about this benefit, saying, hey, why don't you just go and take the risk test and see where you're at, because we have something that may be helpful to you. And now let's talk a little bit about the results from this large school district. As of April 2018, a little over 5,200 district employees have taken the risk screener. 934 district members were committed to the program. And of that 934, 64% remained actively engaged, and 18% had actually achieved the 5 to 7% weight loss. Again, with this group, we provided some incentives, a $10 gift card just for completing the 1-minute, assessment test and quiz. And again, we gave them the Fitbits after they completed the week 4 of the program. And so again, it's all these programs, when you're talking about health, wellness, it's engagement. How do you engage people? How do you get them started? And then certainly, how do you, get them to maintain that commitment? Just, again, some of our lessons learned working with employers to implement the national DPP lifestyle program that we've had are obviously the best success with employers who are very engaged. When we tell them about the value proposition, your ability to improve your employees' health, also the ability to save healthcare dollars, save healthcare costs, right? That's really what employers always want. They want both of those together. Then it seems to be an easier sell. And then employers are engaged and they're working with our vendor. Certainly, it's raising the awareness of type 2 diabetes, the risk and the costs. And another key is having this accessible and available provider network, right? Having choice and many different providers that can provide the service certainly was important. And what we found is this need to kind of have initial and persistent engagement. And so that's something that we've worked hard on. It's an ongoing effort, and but we've had some success so far. And like you said in some of the earlier presentations, the more creative you can get as to engage people, provide the incentives, it seems to really help. Some additional considerations as you move forward, especially in the payer space, it's all about how do you continue to drive program completion and weight loss. We certainly feel that, remember those milestones, if you complete 4 weeks, you complete 9 weeks, I think there's certainly benefits anywhere along the pathway. Obviously, the goal is to get people to complete all 4 milestones and achieve that 5 to 7% weight loss. we know that really makes a significant difference at decreasing that risk of developing diabetes. So we're constantly looking at ways, trying to address dropout and re-engagement. We do have, with these vendors in the contract, a pathway back. So if somebody starts the program, midway through they just disengage and they just don't follow up anymore, they are allowed a way to come back and restart the program. So that was part of our contract with the vendors. And so that is something certainly I would recommend. And I think the other part of it is, culturally appropriate materials. We certainly do offer it, many of these programs in Spanish language, which is important. And out here, certainly in California, we need to even expand that more to other languages. But all those things, digital, in-person, culturally appropriate, all certainly very important. With that being said, I'd like to turn the presentation over to Arlene Gwendon from the National Kidney Foundation of Michigan.
Great. Thank you, David. I really appreciate it, and I'm happy to hear you're going to be able to go back to your home soon. So my goal today is to provide you with some insight on what it's like to deliver the national DPP and eventually the MDPP within the community, and why the National Kidney Foundation of Michigan is interested in doing so. So really, the National Kidney Foundation of Michigan is interested in doing so because prevention aligns very, very well with our mission. And our mission is to prevent kidney disease and improve the quality of life of those living with it. For chronic kidney disease, approximately 70% of chronic kidney disease, the risk factors that are attributed to it are diabetes and hypertension, and it aligns so well that if we can offer evidence-based programs within the community and be successful at individuals adopting healthy behaviors and sustaining those behaviors, we feel like we can really make an impact within the community. The next slide actually shows what it looks like and what our results are to date. We actually owe a new file and updated results this month to the Centers for Disease Control, but thus far we've served over 1,500 individuals that have completed our program, the National DPP. The average weight loss for those individuals is 6%. The recognition factor, as probably all of you know here, is 5%. And the average physical activity minutes for those completing the program is 187 minutes per week. Now, there's no recognition factor on it, although the program goal is 150 minutes per week. And it's critical, really, that both the healthy eating and the physical activity go hand in hand. Although you could do one with the other, you can't sustain a healthier lifestyle without doing both. One of the things that we also measure are not only employee engagement, but are participants really engaging in the program, and are they confident when they complete those 12 months that they're able to sustain those healthy behaviors once they leave the program or once they graduate from the program. If they're not, then we really haven't done our job as well as we could. If they are, then we feel like we've really armed them with the right tools to move forward and create that healthy lifestyle. So as you see from the fourth bullet, 90% of participants are very confident in their ability to eat healthier and be active for 150 minutes more per week. That's a critical success factor for us. And as I go through the presentation, we'll talk about how do we collect that and how do we take checkpoints of those participants throughout the program. So one of the things in launching the National DPP and the MDPP within the community is there are several factors we need to look at, several dots we need to connect. And on this slide, you see 6 of those dots. Community of focus, finding a host site, recruit participants. How will the program be paid for? Who will pay and reimburse participants for their participation in the program? And then what are the available resources, and is it culturally appropriate for the community in which we're launching the National DPP? I'm going to go through each one of these and provide you with an example of what I mean specifically in each area. So the community of focus is our starting point. Where are we going to deliver the National DPP and MDPP? What communities? We have offices in southeastern Michigan and Detroit and Flint and Ann Arbor and Grand Rapids, and those communities are very, very, very different. And some of the ways in which we select where we're going to start, in all honesty, is funding. So if we have a grant and the grant focuses on Wayne County and Detroit, that's where we're going to start our focus and launch and get the other dots and connect those. If we have a demonstration project like we might have with Michigan Medicine, and they want to add in maybe a different but parallel, slightly off the National DPP, maybe a low carb to see which one is more successful, we'll work with them and we'll offer it at a Michigan Medicine location. If we have a food bank that really wants to, where there's a food desert in a community, but they want to really engage underserved areas to participate in the national DPP, then we'll have our their food truck come and provide resources to individuals once they complete a session. So we can begin to really communicate with the community and draw them in. But where we start really is based on a variety of factors, funding not which being the least of them. So once we find a community, who's going to host the event? So as easy as this may seem, it's not, because we're asking organizations in the different communities to at least give us their space for 12 months minimum continuously, or 24 months potentially with a Medicare DPP. So that's not easy to do that from a space perspective. But some locations in some communities, like clinics, we have relationships with. It tends to be for different clinics we work with, whether it's a federally qualified health center or a large university system. We can use their facilities, but after hours. And so that brings up other special challenges of getting people in and out and making sure that site's secure. We sometimes look at recreation centers. Other times, many of our DPP workshops are offered in houses of worship, temples, churches. The focus of where we offer it is what's available, what's easily accessible, and will participants feel safe and secure when they come to that site. That's our goal, no matter what the community is. We also offer worksite wellness, so we'll offer this in the corporate setting, and usually the corporation will provide that space for us to use. Regardless of who the site is, all sites we develop what we call a memo of understanding. And basically it manages expectations. What can that site expect from us when we come in every week, and then in monthly sessions every other week? And what can we expect of them as far as creating a safe and healthy facility and place to hold the national DPP? So once we have the community, we have the host site, we need participants. Just because we have those things in place doesn't mean participants will come. And this is one of the most challenging aspects, is to recruit participants. To recruit them not only to come to the information session. So we have an information session before session 1, and it's to really tell individuals about what the program is, to answer any questions they may have about funding and reimbursement, but also for us to let them know what our expectations are from them, because we hope that they'll be highly engaged, and then what they can expect from us, the support that they can expect from us throughout the program. Sometimes we have host sites that really engage in marketing and recruiting with us. Sometimes we need to do it on our own through social media. And other times when we work with clinics or federally qualified health centers, we have an e-referral in which they can send us referrals for patients who qualify for the national DPP through a HIPAA-compliant secured line. They can go ahead and refer, and then we'll let them know that we received the referral. It's most successful when we receive referrals from clinicians if they talk to their patient first. I know that sounds basic, but I can tell you how many times we received referrals, and we're the first contact. The National Kidney Foundation of Michigan is the first contact of calling the patient saying, hey, we see that you're interested in the national DPP. And they're like, who are you and how did you get my name? So it's really critical that the healthcare provider have that first dialogue. As I briefly mentioned, funding methods are critical. We know that grant funding it ebbs and flows. In many situations where grant funding is, we know that we can support individuals within those workshops. CMS has come on board with the Medicare benefit. That's going to help us with that proportion of the population. We're doing some demonstration pilots with a few Medicaid plans in Michigan, so we know that they're underwriting it and they can support that population, so those individuals don't have to worry about the funding perspective. We have some commercial insurers that we work with that fund at a different rate the individuals participating in the program as long as they qualify. And then some corporations also will open the doors wider, so beyond those who qualify, and let all employees attend, even those with diabetes. So it's very tricky for us, and we work with our coaches very diligently to offer the best program that we can for that population. Where those mechanisms aren't in place, we offer individuals the opportunity to self-pay. They can pay in a lump sum or over a period of time. And if individuals can't afford it, none of these funding mechanisms align with where they're at, we have scholarships that are available, and it's really based on need. So we also look at what are the available resources in the community, because we're there for a year or 2 years, depending on the population we service. And once we leave, we want to make sure that those community resources and those participants can sustain that healthy behavior. So one good example of aligning available resources is one of the clinics that we work with near the Ann Arbor area. actually has a fitness center. The clinic doesn't own the fitness center, but a local community college owns a state-of-the-art wellness center. And they've allowed us, the community college, for anybody that participates in the national DPP, as long as they attend, they get a pass to go ahead and use the fitness facility free. It's really a low-cost one, and in fact, we hold session 5. I also am a lifestyle coach, so I know by the session number, it's like jumpstart your physical activity. We hold it there at the wellness center. And first I thought, it's more than a gimmick. It's really, a lot of people are intimidated by going into a wellness center or gym on their own. We heard that when we held the first session there. I wouldn't have come unless I was with the group and group support. Now I see it's approachable, and I'll continue to attend. And that was great. And that relationship is fantastic. And even when we leave and that program ends, those two organizations are still there. So that's our ultimate goal, is to really show individuals who might not be familiar with those resources that they're truly available for them to use throughout their lifetime. And absolutely, we want to make sure that the programs are culturally appropriate. On the west side of the state, in our Grand Rapids office, they do a fabulous job of working with Latino and Hispanic communities. And they have some very passionate coaches there that not only make sure the food models are appropriate, but the trackers are appropriate, and that the way that we dialogue with individuals in those locations is appropriate, and we're there, and it's a safe environment in which they can come. It's just amazing what that group is doing these days. So I mentioned just really briefly engaging participants, but participants are at the crux. We could have all those 6 factors on paper. It looks great. We got started. We have 12 to 15 participants at a minimum starting the workshop, but we need to engage participants from the beginning. We need to engage them at the information session. We'd have them take a readiness test. If they're not ready at the info session, they might not be a candidate, at least this time around, to continue that program. And we actually ask them, the coach thoroughly engages them throughout, not only during the sessions, but we take checkpoints. And we do a baseline survey, we do an 8-week survey, we do a 16-week, and we do a 9-month, because we want to take checkpoints to make sure, are we missing anything? Are the individuals engaged? Is there a good relationship and strong with their coach? It's really important that we do it throughout. Once you get them in the doors, it's not done, it's just beginning. What you see here on this slide are some really sound bites of individuals, and some of I mentioned the 4 surveys that we provide. What amazing things did they learn, and how would you change the program? We take a lot of their feedback on how would you change the program and incorporate it into our workshops. One good example is healthy recipes. We do a recipe rehab in one of the sessions, and it's great because participants bring in their own recipes and they're more engaged, aside from us giving a script, of here's what you must take. It's like, no, here's what I go home and cook. How can we make it healthier? Because they're likely to continue in that situation than if we didn't do that. So how do we sustain the momentum? We've been successful to date. We've had CDC full recognition for 4 years. We hope to have it much longer. It's been challenging. It's exciting. What's made us successful to date are our high engagement rates, the support that we have in the communities, our different funding partners. Even though those are some of the same factors that will help us be successful down the road, the environment's totally changed. Different funding sources are there. We're looking at doing a blended model with online and in-person to account for what you heard David and others talk about, the virtual DPP. There's more competition, more organizations are getting into the marketplace, and there's growing pains, and we have to get coaches to keep continually being engaged in the program as well. It's not easy. It's ongoing. We're hoping that we can stop and take checkpoints and continue to sustain the momentum that we built for much longer down the road. So the key takeaways: we need to engage participants, we need to collaborate with partners, we need to address challenges, and even when we do all that, we need to keep the main purpose in mind. And the main purpose to me is, for individuals that participate, we need to make sure that we can help them create sustainable, healthy lifestyles. If we forget that, then we won't have a program at all. So thank you for your time, and I'm going to turn it over to Ann for Q&A.
I'd like to turn it over to Susan to see if we have any questions coming in online.
Thank you, Dr. Albright. We do. I first want to remind our online viewers to submit your questions to grandrounds@cdc.gov or via Facebook. Our first question from Samantha on Facebook. She talks about her last pregnancy being diagnosed with gestational diabetes being a real eye-opener. Is there anything that we can do to see that restaurants can provide reasonably priced options for people with diabetes?
Well, to start that conversation, there are efforts going on throughout the public health community working with restaurants and other food service organizations. So there are efforts to really start with the consumers in the community. If people demand things or are interested and they speak to these restaurants and these locations, then they are often interested and willing and listening to their customers. So it should be the customers who put that out there. One strategy that people can often use too is when you go into a restaurant, order your meal and take half of it home. Put it immediately in a to-go container, half of it, and take the rest of it home. So you can also ask the restaurant, but you can also do some things yourself.
Okay, we'll go with another question from online viewers from Sensig. Can you talk briefly, this is for the whole panel, about the they're calling it metabolic surgery. I believe they're talking about gastric bypass and the impact on diabetes overall.
I'll start or I'll answer. There are a few tools in our armamentarium for preventing or delaying type 2 diabetes. You've heard about primarily today the evidence-based lifestyle change program that is really critical. You also mentioned briefly the medication metformin, and there are a couple of others that are also potential candidates. There is the opportunity, and another third tool would be bariatric or various versions of bariatric surgery. Again, a tool in our armamentarium. This is a conversation that people should have with their clinician to determine which of the tools is most appropriate for them. I would underscore, however, that lifestyle is common to every single one. Regardless of whether you have surgery or you're on a medication, lifestyle always wins the day. So it's imperative that you engage in lifestyle and whatever other additional therapies your clinician thinks are most appropriate for you, but definitely talk to your clinician. Let me just pause for a moment and see if there are any questions in the room before we continue with any online. And I know sometimes it takes, good job, Steve.
So this is Steve Redd. I have a question about the challenges in scaling the program. The number of people with prediabetes is pretty large compared to the number of people that you've been able to enroll. And I know that you're working hard to make the program available to more people, but I wonder where are the points where you especially need to make progress?
Yeah, there's probably a lot to say, but I'll try to be as succinct as I can. Yes, there are an estimated 84 million people with prediabetes. Part of the issue we have faced is that people have been completely unaware of this condition, for starters. So we really do have to generate increased public awareness. We must have a national conversation about this, just as we are about opioids and we have about HIV/AIDS. We must have that conversation as a nation. So that's first and foremost. People have to be aware. They have to know. And then it really is about engaging people in the interventions that have been proven to prevent or delay type 2 diabetes. There's a lot of noise out there. There are a lot of things, people trying various programs, people trying all sorts of array of diets that they go on and off. This is definitely an area that is crowded with things that people are attempting to do. So I think part of it then is also focusing on the evidence-based interventions. Third, I would say that also as a nation, we have to get serious about scaling lifestyle. We can distribute medications well. People can get surgical procedures. They know about them. They know where to get them. We have not treated lifestyle in the same way. So I would say that those things are critical. We have to talk more about this. People have to know where they stand. We have to treat lifestyle seriously in the country and be very committed. Look at anything in history. Whether it was sending somebody to the moon, whether it was the Wright brothers launching the first plane, whether it's been any of our conflicts. If people give up, then we will never get where we need to go. So you cannot be faint of heart. We must press on. So having said that, around really getting lifestyle implemented, and for the first time in our history, taking it seriously and not growing faint of heart, we also, as I mentioned in my remarks, must also change the environment in which we live, work, play, and worship. These are not mutually exclusive. In fact, they must be done together. So it requires both, that we are full throttle going after this intervention and getting it scaled, and we are changing the environment and looking at all those potential options and looking at the evidence behind those as well. So it's a dual approach, and they are really complementary and must be done together and taken seriously together.
From the Medicare perspective, I would agree wholeheartedly with everything Ann just said. I think it's pretty simple, though, as I shared in my remarks. Beneficiaries need to know that they're at risk, so they need to know that they're pre-diabetic. So screening by their physician, primary care provider, even a health fair, start the conversation there. We need suppliers that can deliver this service to beneficiaries. So folks that are already CDC recognized, having them enroll, get the necessary support and services they need to be able to do that. But then folks who could be enrolled in Medicare but aren't yet CDC recognized, getting them started on that process, because we know it takes about a year to get preliminary recognition, and then to refer your Medicare beneficiaries to suppliers near them.
And I'll add just one more thing, because sustainability won't happen without funding. And I'm glad that Medicare is going to fund for Medicare beneficiaries, but the rate at which we fund is going to be challenging for individuals, whether you're online or in person, to sustain the program. So let's not forget about the funding.
Well, I know we're at the top of the hour, and any of the questions that we did not get to from online, we will absolutely answer all of those questions for you. So no worries. And if any of you in the audience have questions that we did not get to, the speakers will be here for a bit longer, and you can also give us your question, and we will be sure to get an answer to you. Thank you so much for your interest and participation in this Grand Rounds.
Speakers? We'll see you next month. Public Health Grand Rounds.